there, the recording will be uploaded into the YouTube channel. So allow me to just go into it. Um, so the scope for today, as you instructed me, was to go through the three uh, um, subdivisions of anatomy, that is gross anatomy, microscopic anatomy, and developmental anatomy. So I will try to cover each, but it's a lot. Okay, it's a lot, and I can't promise you that I'll be able to cover uh, everything that you guys have discussed since you joined this institution. It's a lot, but I'll try to just cover in terms of regions. So in case of gross anatomy, I shall have a question, say, from the gluteal region, the hamstrings, that is the posterior thigh, that way. Then in histology, I will have some slides for you. These slides were obtained from the Department of Human Anatomy. There's two slides. We literally went there and took pictures. This is now where Sami Haron came in when we were doing BSc back in the year 2023, 2024. I remember we would spend the night in the department taking pictures of these slides, and then we made a compilation of those slides, because you will be using those slides in the department in your exams. That is what they'll put them. They'll put those slides in the microscopes, and so you need to familiarize yourself with those slides as they are. Then for the developmental anatomy, I will mainly use some images of some congenital anomalies and some common body parts. You will have a look at them, and I hope by the end of this session, I want to keep it brief, but as informative as much. So allow me to start with the first question, and the way we shall do these questions is very easy. I shall just project a question, and then you guys just answer in the chat box what you think the correct answer is. That way, it will be more of a discussion. Okay, it will be more of a discussion rather than me coming here and giving you a lecture. And by me giving you a lecture, you guys will be very bored. Some of you will even go to watch that game. I know the game is nearing, but I urge you for just today, just today. You can just stay here, okay? So let us start. The first question. I'm sure some of you have seen this image somewhere. But let us start. First question, identify structures labeled B, D, and E. So you can just type in the chat box what you think B is. So you can write B, then you say it's this muscle or this nerve or whatever, then D, that way. You can send them separately or all of them. So let me check the chat box, and there is no wrong answer. There is no wrong answer. B, piriformis, very good, Chepchirchir. Juliet Kuria, D, quadratus femoris, that is wonderful. Yes, I can see piriformis, piriformis, wonderful, that is very good. Okay, B is piriformis. Now let us go to D, quadratus femoris, wonderful. And finally, what is E? Yes, what is E? Guys, what is E? E, superior gluteal vessels. Inferior gluteal, very good, Very good, very good. E is inferior gluteal nerve, It's inferior gluteal nerve because you can see it is emerging through the infrapiriformic. It's a nerve, It's not the vessel, it's the nerve, that one. It is emerging through the infrapiriformic compartment, and then it is going to supply that big muscle known as gluteus maximus. Yes, gluteus Maximus. Um, okay, allow me to join with another device so that I can see you. But that way I think I'll have Sorry, I'm trying to see if there is a way I can join with another device so that I can be reading your comments on one device, and the other one I'll be asking the questions. Okay, I think I can. Okay. Um, so you guys can continue answering the second part of the question as I join with another device. You can, what is the root value of A and C? So before telling us the root value, tell us what A is and what C is as I join with another device. Yes, what is A and what is C? Hello, guys. What is A and what is C? So A is superior gluteal nerve, and the root values L4, L5, S1. Okay. Superior gluteal nerve, L4, L5, S1. Okay. So I think all of you have uh, come to the conclusion that, okay, let me do this. Wonderful. I think I've been able to join with another device. So I think all of you have agreed that A is superior gluteal nerve, which is wonderful. And C is the posterior femorocutaneous nerve, or the posterior cutaneous nerve of the thigh. Wonderful. That's wonderful. So, yep, this is let me take a pointer. Yep, that's your posterior femorocutaneous nerve. And you can see that's the perineal branch. That's the perineal branch of the posterior femorocutaneous nerve, which goes to supply your posterior one-third of your scrotum, and in males, and the labia majora in females. So that's the posterior femorocutaneous nerve, and A over here, imagine through the supra piriformic compartment, that's your superior gluteal nerve, and you can see it's running in that intermuscular plane between that muscle there is gluteus minimus, and this is gluteus medius. So it supplies the two, and also terminates in the body of tensor fascia lata, which it also supplies. So what is the root value of superior gluteal nerve? You've correctly said L4, L5, S1. That's good. And the posterior femorocutaneous nerve is S1, S2, and S3. And yes, you should know the root values of these nerves. Okay. Then what's F? What's F? Yes, what is F? Okay, let me see what you're saying. Pudendal nerve. Okay, yeah, that's wonderful. That's your pudendal nerve. But pudendal nerve, remember those structures which emerge through the infrapiriformic compartment and immediately enter the pudendal canal via the uh, lesser sciatic foramen, include your pudendal nerve and also pudendal artery and pudendal vein. So the bony landmark used to locate it is the ischial spine. That's wonderful, guys. Um, um, okay. Someone is requesting a meeting summary. Now, why would you want a summary and there is a recording? Okay. I think, yep. Second question. Yes, this one you may or may have not seen this image. So I want you to identify A to E. So what do you think A is? What do you think B is? Yeah. Yeah. Guys, let us, yeah, just name one. A, sciatic nerve. Wonderful. That's very good. A is sciatic nerve. True. What's B? What is B? B, sural nerve. Um, um, no. B, tibial nerve. Look at it. It's not tibial nerve. Very good, Sammy. It's your small saphenous vein, eh? Small saphenous vein. B is your small saphenous vein, okay? Please look at that structure and see where it is terminating, eh? It's terminating into the structure labeled F, eh? Okay. What is C? What is C? Popliteus. Do you agree C is popliteus? What is C? Guys, what is C? Plantaris. Plantaris. Okay. So I can see we have people saying popliteus, others plantaris. So popliteus. Okay, okay. So some plantaris, others popliteus. So who is correct? Okay, I tend also to think that's plantaris because popliteus forms the floor. It will be deeply placed. It will be deeply placed, but this looks like more of a inferolateral boundary. So the inferior lateral boundary, that's more of popliteus, eh? Okay, sorry, plantaris. Did I say popliteus? Wow. Okay, what is D? What's D? Tibial nerve, eh? Tibial nerve, very good. Now that's your tibial nerve, very good. What is E? What is E? What is E? Common peroneal, um, um, common peroneal, is it? Superficial peroneal, nerve to popliteus, suro, very good, Maya Oduka and Daniela Oyua. Yes, that's your surocommunicating nerve. That's your surocommunicating nerve, eh? Remember, suronerve comes from your tibial nerve, but the surocommunicating comes from your common peroneal nerve, eh? And you can see this guy is originating from the common peroneal nerve, eh? Okay, I think we have named, okay, F, what is F now? What's F? What's F? Very good. That's your popliteal vein, eh? Popliteal vein, very good. Wonderful. So I think we have named all, eh? So what are the articular branches of D? So what branches does the tibial nerve give within the popliteal fossa? What branches? Please repeat on suro and surocommunicating. Suro nerve is the only cutaneous branch of tibial nerve within the popliteal fossa. Okay, so suro nerve comes from tibial nerve, but surocommunicating comes from the common peroneal nerve, and it joins. So suro nerve, you'd see suro nerve if it was here, you'd see it coming vertically downwards, but then the pseudo-communicating takes this, it comes from a lateral aspect and then moves inferiorly to join now the pseudo nerve at the level where the muscle belly, where the muscular part of gastrocnemius becomes the tendinous part. Eh? So somewhere along the mid level of the posterior leg, that's where you'd see pseudo-communicating joining pseudo nerve. So pseudo-communicating um, um, uh, is from your common peroneal nerve. So what are the branches? What are the branches? Articular. So please note the question. State the articular branches of D, which you named as tibial nerve within the popliteal fossa. So what are the articular branches? Muscular, articular, sensory. No, 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 no. Suro nerve. No, suro nerve is not an articular branch. That's a cutaneous. Superior medial, very good. Inferior medial, very good. Middle genicular nerve, that is wonderful. Okay, or superomedial, inferomedial, and middle genicular branches. That is wonderful. Those are the branches, the articular branches of tibial nerve. No, no. Now, medial and lateral. Okay. Suro. Medial and lateral suro. I know there are some books which tell you, okay, you'll find some books or some anatomical texts suggesting that suro nerve, that one which comes from tibial nerve, you can also name it as medial suro and suro communicating as lateral suro. I've seen it and I am aware of this. Um, um, whether it's correct or wrong, that remains a subject of debate. Okay, so this medial lateral suro, those are newer terms. The older terms are suro and suro communicating, and those are the terms which, okay, the person who taught me anatomy was an old guy, so maybe uh, they were taught to it's suro or suro communicating, but you'll find the new anatomy suggesting that that you can name it as medial suro and lateral suro. Okay, it's also okay. Okay, I think we've named the articular branches, which are the genicular nerves, eh? Great. On to the third question. Now name A, C, and E. Guys, first of all, what region is this? What region are you observing here? So that you can orient yourselves. The region, what region? Okay, thigh. Oh, I like femoral triangle. Wonderful. This is the femoral triangle or the upper part of the thigh. Very good. So you need to know how structures are arranged within the femoral triangle. So, guys, tell me what is what? What's A? What's A? Very good. That's the base of the triangle. That's your inguinal ligament, eh? Inguinal ligament. Then a question which can be asked about that ligament is, can you name the medial attachment? Where does it attach medially? What is the medial attachment of A? The medial attachment of um, the inguinal ligament. What is the medial attachment? Pubic tubercle, wonderful, okay? And then I expect you to know that laterally it is attached to your anterior superior iliac spine. Okay? What is C? What is C? What is C? What is C? Femoral artery, profunda femoris. Is it femoral artery? Very good, eh? That's your profunda femoris. You can also call it deep femoral artery, okay? So deep femoral artery. So please note that D over here is your common femoral artery. From the common femoral artery, you get C, which is your deep femoral artery. And this one, which we now continue to your adductor canal, is the superficial femoral artery, which we now become the popliteal artery at the level of the adductor hiatus, okay? So that's how you name it, or name them, okay? So common femoral artery, deep femoral artery, superficial femoral artery, or the other name of deep femoral artery is profunda femoris. So what are the branches? Name some three branches of the common femoral artery apart from C. So apart from the deep femoral artery and superficial femoral artery, what are some other branches which come from the common femoral artery? Very good. Superficial epigastric, very good. Superficial circumflex iliac, and the superficial external pudendal. Also, does the deep external pudendal come from the common femoral artery? Does the deep external pudendal artery come from the common femoral artery? Because it's a yes or no question. Uh, okay. Yes, yeah? Yes, okay. So apart from saphenous artery, okay, I have, guys, saphenous artery. Eh, 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 eh. No, 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 guys, let us be serious kidogo, because I don't think we have a saphenous artery. Okay, naambiwa iko. I am wondering, does it come from the common femoral artery? Iko. Okay. So I don't think we have a saphenous artery coming from the common femoral artery there. Okay. So I just wanted you guys to name branches of the common femoral artery. So superficial epigastric, superficial circumflex iliac, superficial external pudendal, and deep external pudendal. Those are the four branches coming from your um, uh, common femoral artery. Okay, then name this structure pointed here. I know it's not green. This is more of blue. What structure is that one? That one. Yeah, that one. What structure is that one? Aha, very good. That's your saphenous nerve. Saphenous nerve. It's the only cutaneous branch from the posterior division of femoral nerve. And it supplies its distribution. If asked the distribution, you just say as whoever full stop said, cutaneous innervation of the medial leg and the foot up to the level of the first metatarsopharyngeal joint. That's how you describe the distribution. Okay, so cutaneous innervation. So that's the form, and then you tell us of what is the extent of this cutaneous innervation. That's wonderful. Um, what about articular via infrapatellar branch? Um, okay, I think it also gives an articular branch. I I am not sure about that. I'll have to confirm. Is it an articular branch or does it participate in the formation of the prepatellar plexus? Is it an articular branch or a cutaneous branch to the knee? I'll have to confirm that. I am not sure about that. If it's an articular branch or a cutaneous branch which participates in the formation of the prepatellar plexus, which is a cutaneous. Yeah, I think it's a cutaneous. Yeah, it's not an articular. I think it's a cutaneous. It's more of a cutaneous. Are you supposed to state the area to innervates organs? So if asked distribution, you just say as a, okay, now this guy who is full stop, as he said, cutaneous innervation of the medial side of the leg and the foot up to the level of the first metatarsopharyngeal joint. That's how you state it, eh? Not the branches. Okay. Um, guys, give me a minute kidogo tu. Okay. I am back. Sorry for that. I am trying to multitask, cook, and still teach you guys. So, yep. Uh, So, on to the fourth question. Now, name these ones. A, B, just name everything. Just name everything. And yes, you should also expect such images in your cards. They will give you also radiological images. So do not be bamboozled when you find such images. A hip joint. Acetabular fossa. I think acetabular fossa is wonderful. Okay. or the acetabulum, okay? A is the acetabulum. Acetabulum. Okay, what's B? What's B? Now this one is a yeah, B is the lesser trochanter. Wonderful. Lesser trochanter. What is C? What is C? What is C? Very good. Very good. Shalom. That's the intertrochanteric crest. Okay? It's the crest. The crest, you can see it on an X-ray. The line is not visible on an X-ray. So that's the intratrochanteric crest. What's D? What's D? Very good. That's your greater trochanter. What's E? What is E? Okay, neck. That's the femoral neck. And what is F? What's F? That's the femoral head. Wonderful. Regarding the femoral head, I'll ask you again and again and again, please go read the vascular supply of the head of femur in children versus in adults. 2, familiarize yourself with the different types of fractures which occur on the femoral neck. Okay? So please go read on the different types of fractures which occur on the femoral neck. So those basicervical fractures, those fractures, please go, the intertrochanteric fractures, the paratrochanteric fractures, please just go familiarize yourself with those fractures. Okay, what is the type? Okay, name this joint. What is the name of this joint? What is the name? Okay, why is C not quadrate tubercle? Good question, because quadrate tubercle is along the intertrochanteric crest. So I think even if someone was to say quadrate tubercle, I would also agree that is correct. So the name of the joint, okay, guys, no. I asked you just the name. What is the name of the joint? Yes, the name of the joint is hip joint. That is the name. What is the type? What type of joint is the hip joint? What type of joint is the hip joint? Type, just type. The type is synovial. Nothing more, nothing less. Ball and socket is not a type. Guys, the type is synovial. What is the variety? What is the variety? Now that is why you bring ball and socket variety. Okay? So the ball and socket variety is in terms of the shape of the articulating surfaces. So if you are to ask, state its variety in regards to the planes of movement. So what would be the variety in regards to the planes of movement? Yeah, it will be a multi-axial, okay? It will be a multi-axial. So it depends on the question, eh? So is it variety in regards to the shape of the articulating surfaces, the planes of movement? Okay. So guys, just to take you back to your first lectures, I know Dr. Awori taught you this. You are told that the human body just has joints. The human body just has 3 types. Types, I'm saying types. Just 3 types of joints. Yeah, just 3. Is it fibrous? Is it cartilaginous? Is it synovial? Then you are told to go read the 5 cardinal features of a synovial joint. What are the cardinal features of a synovial joint? Tell me, what are the cardinal features? Characteristic features of a synovial joint. Very good. One, presence of a synovial membrane. Okay, it moved. Stop misbehaving. Okay, okay. One, presence of a synovial membrane. Two, articular cartilage. Very good. Presence of a joint cavity. Presence of a joint capsule. Okay, so those are the characteristic features of a synovial joint, and also synovial fluid. Okay, okay. So please go familiarize yourselves with the characteristic features of a synovial joint. Then under fibrous, you guys were told under fibrous you have three type. Let me call them varieties. So it can either be sutures, and if you decide to pursue anatomy further, you will find out that there are so many types of sutures. Okay, you will also find others known as gum forces and others known as syndesmosis. Okay, those are the fibrous varieties. Okay, interosseous, that one, no, I don't think interosseous is there. Those are the three. Then under cartilaginous, it can either be primary or secondary. Primary ones are also known as your synchondrosis. So here, hyaline cartilage forms a joint with a bone. So an example is your epiphyseal growth plate. And then the secondary are your symphysis, your symphysis. The beauty about symphysis is that they are found along the midline of the body. So the midline of the body, the mid-sagittal plane, that's where they are found. So you start with the lower jaw, the symphysis menti between the two halves of your mandible. Then you go to your syphisternal joint, syphisternal joint, manubrosternal joint, your pubic symphysis, and also the intervertebral joints, between two vertebrae, because you have fibrocartilage, they are acting as the intervertebral disc. It falls there, okay? Then synovial now, that one kindly go and read how the various varieties of synovial joints are classified. Okay. So, um, so what attaches to B? Name the structure that attaches to B. Okay, idiosaurs, Idiosaurs. Wonderful, wonderful, wonderful. Please note that idiosaurs is the chief flexor of the hip joint. Now, the next question is testing your knowledge of the part of the leg and also the foot. So please note, what is the name of this area? The one I'm displaying here. What area is this? Okay, what is the area? Ankle. Very good, Helen. This is your tarsal tunnel. This is your tarsal tunnel. So, question is, do you know structures that traverse the tarsal tunnel? Because if you do, then you literally can name all the muscles which originate from the posterior compartment of the leg. Okay? Because in your exams, what they'll do is, if they want to tag a muscle, the easiest way to tag a muscle is to tag its tendon. Okay? So if you know how these tendons are arranged in the tarsal tunnel, you'll have a very easy time to identify that muscle. Okay? So A, I saw someone say A is plantaris. Okay, that's great. What's B? What's B? What is B? Tibialis posterior tendon. Wonderful, wonderful. Even if you say tibialis posterior, You are still correct, eh? You don't have to put tendon, but it makes no harm for you to say tendon, okay? So tibialis posterior. What is C? What is C? What's C? Flexor digitorum longus. Wonderful. Flexor digitorum longus. Wonderful. In your exams, avoid using FDL. I'll advise you that kindly just write it in full. Flexor digitorum longus. Okay, that is C. What is D? What is D? Posterior tibial artery. Okay, posterior tibial artery. Very good. And E? What's E? E is your tibial nerve. Wonderful. I I I I I am impressed that you guys know the structures traversing the tarsal tunnel. Wonderful. What are the terminal branches? What are the terminal branches of the tibial nerve? How does the tibial nerve terminate? What are the terminal branches of tibial nerve? Lateral and medial what? Plantar nerves, eh? Lateral and medial plantar nerves. Wonderful. B is tibialis posterior. What are the actions of tibialis posterior? What are the actions? What are the actions? Foot inversion, wonderful. And ankle plantar flexion, okay? So foot inversion and ankle plantar flexion, eh? Please, when say the action of a muscle, kindly tell us what joint, okay? So if you say the action of quadriceps femoris is extension, we don't know if you mean ankle extension or hip extension. So kindly make it a habit to include the joint. So you can say extension of the knee joint, eh? Or knee joint extension or knee extension. Okay. Okay, it also maintains the medial longitudinal arch of the foot. I totally agree. I totally agree. Yeah, so subtalar inversion. Wonderful. Okay, I am done with the lower limb. If you have not yet noticed, I am done with the lower limb, but we can all agree that I have not tackled any question in the anterior aspect of the thigh. I did not uh, tackle the quadriceps. I also did not tackle anything to do with the knee joint, which is very, very important. As an anatomist, you should know the knee joint because once you come to clinical years, in orthopedics, you'll find very many guys with the pathologies of the knee joint, and you need to understand the anatomy so that you can know what is wrong, okay? Especially sports injury. Those people will come with the torn anterior cruciate ligaments, so you need to know how will that present the anterior drawer sign, how do you elicit it? Yep. Then I did not touch on the anterolateral compartments of the leg, so those muscles of the anterior and the lateral compartments of the leg. I also did not touch on the dorsum of the foot. Eh? So please go do that. Eh? Kelly Joy has already answered. Hey, do we need to know foot muscles? Okay, nobody will kill you for knowing them. So if you have the time, you can always go through them. Those four layers of the plant aspect of the foot. Maybe nobody will ask you a question, but why not know them? But for the dorsum of the foot, yes. For the dorsum of the foot, someone will literally point flexor digitorum brevis and flexor hallucis brevis, and they expect you to no. Those are actually of the of the of the plant aspect of the foot. Yeah, those extensors, extensor digitorum uh, brevis, extensor hallucis brevis. So please be able to know the muscles of the dorsum of the foot. For the plant aspect, okay, maybe they might overlook that. I said maybe. I did not say they will overlook that. I said maybe. So don't be surprised if they don't overlook it. Okay. Identify A and D. A, clavicle. D, anterior fibers of deltoid muscle. Huyu anaweka, why are you questioning yourself? A, clavicular head of pectoralis major. D, anterior fibers of deltoid. Huh? A, A, A inakaa clavicular head of pectoralis major. A, clavicle. I think A is clavicle. A is just clavicle. That's your clavicle. Now D is now the muscle, eh? Yes, A is clavicle. Now B is your clavicular head of pectoralis major. Okay. Um, okay. Actually, D is not a clavicular head of pectoralis major. I think that was a wrong on my side. Yeah, that's the anterior fibers of deltoid. Sorry for that. Okay, I'll make that correction before sending this presentation. Okay, actually I named B. Okay, B is a clavicular head of pectoralis major, but okay, D is the one which is the anterior fibers of deltoid. Sorry for that mismatch. Yeah, so B is actually the clavicular head of pectoralis major, but the question wanted us to name D, which is now the anterior fibers of deltoid. C C is there. C is the sternal. What is C, guys? What is C? What is C, guys? Yeah, C is your sternocostal head, eh? The sternocostal head of pectoralis major, the sternocostal head. What is E? What's E? Guys, what's E? What's E? Yeah, that's your cephalic vein, eh? That's your cephalic vein. Wonderful. So name any two muscles attached to A. Yeah, go ahead. So pectoralis major, subclavius, sternocleidomastoid, trapezius, um, 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 that's deltoid. Yeah, I think we are fine. Eh? Yeah. Now your work is don't just know them, know actually where they attach. Eh? Know where they actually attach. Platysma. Hmm. Platysma. Does it have a bony attachment or is it a purely subcutaneous muscle? Is it does it have a bony attachment or is it purely found within the subcutaneous tissue? JP, does it attach to a bone or is it purely subcutaneous? Because I tend to believe it's a subcutaneous muscle. It's just found under the skin with no bony attachments. Inferior angle of scapula. Inferior angle of scapula. Platysma. Platysma ni nini? Oh, it's a muscle of facial expression. Yeah, I can see some people have decided to even now go and study head and neck. They are already in head and neck. They are already studying the muscles of facial expression, which is okay. Okay, which is okay. Ati kwa washosho hizo lines za no 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 no. JP, hey, what do you mean? You can also elicit platysma on yourself. You don't have to be a show to elicit it. Ama, you are saying those of us who can elicit it are shows. Huh. Okay. I think you guys have done a great job telling me which muscles attached to the clavicle. So, name the structure. Which structure is pierced by cephalic vein before it terminates? The clavipectoral fascia. You guys, I think eh, you guys have already typed. You just wait for me to go to that question and you just press send, which is good. The clavipectoral fascia. So clavipectoral fascia is pierced by the following structures. I will, and even Ayub has told us another name of clavipectoral fascia as the costocoracoid membrane. Okay, so it is pierced by cephalic vein, the lateral pectoral nerve, okay, thoracoacromial artery, okay, and the lymphatics. Okay, okay, I agree with that. So it can either be pierced by the thoracoacromial trunk, or whatever you are referring to as the thoracoacromial artery, or the individual branches. Those individual branches, the acromial branch, pectoral branch, clavicular branch, and the deltoid branch. The separate branches can pierce it separately, or in most cases, it's just the trunk which pierces it. And lymphatics, yep. Aha. Mhm. Okay. Now to the axilla. Do we say deltopectoral lymphatics? Lymphatics are not named. They are just lymphatics. So you can just, if you want to be more scientific, you can just say lymphatics accompanying cephalic vein. You can just put it like that. Okay, what is A, B, D, and G? So what's A here, guys? What's A over there? Lateral cord. Wonderful. Wonderful. This is very good. What is B? What is B? What is B? Musculocutaneous nerve. This is wonderful. If you have not yet answered the question in the chat box, Buana, kindly do answer. Okay. What is C? What is C? What is C? Radio nerve. Radio nerve. Very good. What is D? What is D? Um, Alna, so the debate is it axillary artery or is it brachial artery? I also tend to think this is more of, let me see where the point weight is pointed. I tend to think this is more of brachial, eh? This is more of brachial. This is more of brachial, okay? So let me ask this question. At what point does axillary artery cease to be so and becomes brachial artery? So at what point? So at the lower border of teres major, the lower border of teres major, I cannot, teres major. Okay, don't think I can elicit teres major on this image. So this is more of brachial. And then what is E? What's E? What is E? What's E? Median nerve. Median nerve. No, 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 it's not ulnar. It's median nerve. That's median nerve. What is F? So what is F? Yes, now F. F is your ulnar nerve. Ulnar nerve. And what is G? What is G? What lies medial to ulnar nerve? The mediocutaneous nerve of the forearm, the medial antebrachial cutaneous nerve. So the medial cutaneous nerve of the forearm or the medial antebrachial cutaneous nerve. Right. So I know you guys use that M. You can try to elicit here as that one. So musculocutaneous, lateral root, medial root of medial nerve, then ulnar nerve, then this is your medial cord. So this here is your medial cord. Okay. Yep, I think so what is C? C, we named it as the radial nerve. Can you just guys tell me some possible entrapment points? What are some possible entrapment points of the radial nerve? One, arcade of Frost. So what is arcade of Frost? Spiral groove of humerus. Axilla. Okay, how in the axilla? How in the axilla? How can it be entrapped? Between which two structures? And you say in axilla? Where? Because the axilla is so big. Lower triangular space. Supinator muscle. Lateral intermuscular septum. RBO. Wonderful. Very good. So, hey, who was to tell me what is arcade of Frost? You guys just wrote it there and then superior border of supinator. Okay, yes, arcade of Frost is a fibrous band. Where is it? Where is it located? What is this you are calling arcade of Frost? Yes, whoever 4D, whatever that is, it's the space, okay, within supinator. So radial nerve passes within the substance of supinator muscle. That is what is referred to as the arcade of Frost. Okay, so E you named E as medial nerve. So name two muscles of the hand. Name two muscles of the hand. Radial tunnel. Huh. Is it the radial tunnel? Is that radial tunnel? Do we have radial tunnel? Okay, I am hearing these things. I know we have a cubital tunnel and a carpal tunnel. Radial tunnel. Ah. Okay, we were naming E. Name two muscles of the hand which are supplied by medial nerve, and I can see people saying brachialis, brachioradialis. You have a brachialis in your hand. This is majabu. Hmm? Brachialis, medial half. You have a brachialis in your hand. Opponent's policies, very good. The lateral two lumbricus, okay, the lateral two flexor policies, brevis, wonderful, wonderful. Opponent's policies, okay, wonderful. Abductor, abductor policies, very good. Is it abductor policies brevis or is it abductor policies? Do you have a brevis? Does it have a brevis, that muscle? Because I can see some is brevis, some is just abductor policies. Okay. Kindly write the full names of the muscle. Okay. Kindly write the full names of the muscle. Don't just write abductor policies because if you have a long as, then that does not hold. Yep. So kindly look at the question, because these people who are telling me brachialis and those others, guys, first of all, where does medial nerve? Does medial nerve have any business with the brachialis in the first place? Eh? Does medial nerve have any business with brachialis? I am shocked. I am shocked. I am very shocked that they are saying brachialis, medial nerve. Okay, name F and state one entrapment point in the hand. So F is your ulnar nerve. Where is it entrapped in your hand? Guyon's Canal. Wonderful. I will not even add anything more. That is wonderful. So here, I sat down. I took my time to make this table for first years. So that when they are asked um, um, the entrapment points, they just have this table which they can refer very fast, and then they can know the entrapment points. I will not go through it. Admin is requesting to record to their computer. Today, I am recording for you guys. I am recording for you. You will get the recording. Number 8. What is C and what is E? Aha. First of all, what region is this? What region are you looking at? Let us start there. Because that way we can have an idea. HUH is saying posterior arm together with Dan Mwangi. And I agree. Posterior limb. Which limb? Upper limb, lower limb, posterior arm. I think we can all agree this is the posterior aspect of the arm. Okay. So what is C and what is E? What is C and what is E? C, radio-collateral artery. Okay, and E, middle collateral artery. Okay, the rest. Kimjibu, guys. Bacteria is saying radio collateral artery. Radio nerve. Okay. Yeah. Posterior fibers. No. Ni C na E. Okay. A from virus. Posterior fibers of deltoid. Okay. Okay, and we agree. C and E. Just restrict yourself to that so that we can, guys, and kindly let us move at a faster pace because now time is not on our side. What is C and what is E? Any other one, anyone who opposes radio collateral and middle collateral, anyone else who has opposing views? Ama you all agree to that? Ama you have no idea of what is happening here? Okay. So it seems nobody got C, which is the deep brachial artery. So guys, kindly remember the radial nerve within the spinal groove will always be accompanied by the deep brachial artery, also known as profunda brachialis. So, and it comes from the brachial artery. And how does it terminate? It gives rise to the radial collateral and now the middle collateral, with E now being the middle collateral artery. Okay. So this is now the middle collateral artery. Okay. And it terminates within it forms part of the cubital anastomosis. Please guys, go read the arteries which participate in the formation of um, um, the um, the cubital anastomosis. So I can see people saying if E is middle, C should be radial. No. Radial will, so this is still brachial, but from this brachial, you'll get a radial. So the continuation, the direct continuation of now the deep brachial is now the radial collateral. Guys, please go read which arteries participate in the formation of cubital anastomosis. Kindly. Hii nayo nimewashika. This one I have caught you guys. Okay? Kindly go read. on the posterior arm. Okay? Kindly go read on the posterior arm, especially the vessels. Can see someone saying ni mbaya. Okay. Kama ni mbaya, usijali, takupatia brufen. Okay. So name D, its root values, and two entrapment points. What is D? What is D? Radio nerve. Wonderful, wonderful. Radio nerve. Its root values. Root values. C5. Guys, when asked the root values, please kindly refrain. Kindly refrain from saying what Kanye Dan is saying. Kindly refrain from that. Kindly say C5, C6, C7, C8, T1. Kindly put it that way. Okay? Yes, as a virus and that other guy is saying. Please don't put it this way as I have here. I kindly put it as Abdul Karim has put it. What is B and F? What is B? First of all, what is B? What is B? Lateral head of triceps. Okay, lateral head. Naona hizi ni picha zinatumwa huku. Huh. I think we can argue with whoever her is on if that is radio collateral or the deep brachial artery. Okay. Lateral head of lateral head of triceps. And what is F? What is F? What is F? Long head. Okay, so where do they come from? Where does the lateral head come from? So the above the spiral groove. Okay. So the oblique ridge above the spiral groove. What about F? What about F? Infraglenoid tubercle. Wonderful. Infraglenoid tubercle and on the shaft of humerus above the spiral groove. Okay. So I can tell you this for sure. In your exam, you'll find a scapula and you are needed to know the muscular attachments. You know, I can tell you for free. Okay. What is the name of this anatomical space displayed here? What anatomical space is shown in this image? Very good. The anatomical snuff box. The anatomical snuff box. Wonderful. What is A and B and what innervates them? A. I can see people saying A is abductor pollicis longus. Okay. And what is B? What is B? What is B? Extensor pollicis. Okay, I can see brevis, others longus. So what is what? Is that the brevis or the longus? Yes, I think it's the brevis. It's not the longus, eh? Guys, please know the boundaries. The boundaries of the anatomical snuff box. So what is the innervation? What is the innervation of abductor pollicis? Yes, abductor AB, abductor pollicis longus and extensor pollicis brevis. What is the innervation? Posterior interosseous nerve. Virus. Virus is saying median nerve. Oh. I hope you do not spread that. It is posterior interosseous nerve, which is a branch of I was to say median nerve. Hmm. Radial nerve, okay? All right. What is C and D, and where are they attached? What is C and what is D? What is C? What is C? Extensor pollicis longus. Okay. Okay. If C is extensor pollicis, so what is C? First of all, what is C? Is it extensor pollicis longus? Is C extensor pollicis longus? True. No, 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 no. I think we will disagree on that. So C is extensor carpi radialis longus, according to uh, HUH and the others who. So extensor carpi radialis longus. Okay, according to her, it is brevis. So is it longus or brevis? Because you need to know structures within the anatomical snuff box and how they traverse that snuff box. Okay, so I can see majority have decided is longus. Majority have decided is longus. What about D? What is D? Now what is D? If C is extensor carpi radialis longus, what is I can see her is still insisting it is brevis and not longus. Okay, E. What is No, no, no. We are dealing with C and D. We just want C and D. No, not E. We are not in E. We just want C and D. So C, according to her, is brevis. The others, they said longus. And we are talking about extensor carpi radialis. Some are saying brevis, others longus. Okay. So according to them, C is longus. Okay. Sasa, her has already changed. Sasa ameenda longus. Eh, 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 eh. Hmm. Okay, so C is extensor carpi radialis longus and D is extensor carpi radialis brevis. Where are they attached? This study. Where are they attached? This study. What is attachment of C? These two attachment. Where is it attached? Guys, you need to know muscular attachments. So base of second metacarpal, whereas D is attached to the base of the. Where is D attached? Base of what? Third metacarpal, okay? So, guys. So, C is extensor carpi radialis longus, base of second, and D is extensor carpi radialis brevis, base of the third. Okay. Identify E and state two branches within the anatomical space. So, what is E? What is E? Guys, what is E? Yes, that's the radial artery. So what are the branches of radial artery within the anatomical snuff box? What are the branches of the radial artery within the anatomical snuff box? Princeps, pollicis, radialis, indicis. Is it? Are those branches given within the anatomical snuff box? Hata mimi nitasema hapana, no. Superficial radial artery. Hapana, hapana. What are the branches of radial artery within the anatomical snuff box? Okay, sasa muscular. Ay, branch to carpal arch. Eish, what is that? Very good, eh? the first dorsal metacarpal artery. That is wonderful. First dorsal metacarpal artery. Wonderful. That's good. Another one, posterior carpal. Is it post? Yep, it's the posterior carpal, also known as the dorsal carpal artery. Okay. Yep, so dorsal carpal artery and the first dorsal metacarpal artery. Those are the branches of the radial artery within the anatomical nerve box. Radialis indicis, princeps podicis, those are given when the artery now is not within the confines of the anatomical nerve box. Higher. Question 10. Name A and B and state the innervation. What is A? Guys, what's A? Very fast. What's A and what's B? And yes, unlike the foot, where we did not bother you to know the muscles of the plantar aspect, you will be bothered with 101 questions to know the muscles of the hand. Vena, no, 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 no. Vena is not a muscle. So what muscles of the, yes, it's the vena eminence, but you need to know the specific muscles of the vena eminence. So A, is it adductor? Whitney, is it adductor or abductor? And also M, is it AB or AD? Okay, B is flexor pollicis brevis. Okay, B is flexor pollicis brevis. We are asking A, is it abductor pollicis brevis or adductor pollicis brevis? Because that is where I can see the issue is. Yes, kindly note it's AB, okay, not adductor, it's abductor pollicis brevis. What is the innervation? What is the innervation? Very good. Recurrent branch of median nerve. Very good. And now this is the recurrent. C is now the recurrent branch of median nerve. Okay. Um, so we have named it as the recurrent branch of median nerve. So C, what is the deformity which results from injury of that nerve? Aha, very good. Ape hand deformity. So if I ask you, can you describe what is an ape hand deformity? The deformity is ape hand. Can you describe an ape hand? How would an ape hand present? Atrophy of, no, 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 no. It is the inability to do what? What can't an ape do that you as a man can or a woman? That's why it is called an ape hand. What can an ape do that you can do? Yeah, inability to oppose. Very good. That's what you say. Okay? No, 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 no. Muscle atrophy will come on later. Atrophy will come on later on. Atrophy is from disuse. When you don't use that muscle, it atrophies. But atrophy won't, if your recurrent median nerve is injured right now, trust me, by tomorrow morning, you won't have atrophy of your thinner muscles. No, 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 no. Atrophy will set in months later from disuse. So what comes in is the inability to oppose the thumb. Why? Why is it that now you can't oppose your thumb? What has happened? Guys, why can't you oppose your thumb? What muscle has been no, 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 not thin eminence. Paralysis of opponent's policies. Very good. Very good. It is the opponent's policies that has now been eliminated or cannot now act. And that means you cannot oppose. So an ape hand simply refers to a non-opposable thumb, a non-opposable thumb. And if your thumb cannot oppose, you won't have that grasp of structures as someone had said earlier. Okay, please go find out. You know, students will be asked, if you injure your ulnar nerve, what is the deformity? They will tell you ulnar claw hand. Now ask them, define that ulnar claw hand. how does it present? And you'll see wonders. Students just know it's an ulnar hand, but they cannot tell you the anatomy behind that ulnar hand. The hand of benediction, they know it's because of injury of median nerve, but ask them why. Why is the hand of, why, how does it present? Please, guys, go find out. Those are the type of questions you find in your Viva exams. Okay. D is ulnar artery. I don't know why okay, I told you that one. Yeah. What is E and F? What's E and F? What is E and F? This is also F. This is also F. All those are F. Let us start. What is E? Also, this is E. Yeah, this structure there, that's E. Yeah, very good. Whoever done is okay. You are literally there, but you are not there. Bacteria also you are there. Just check at it. Does it seem like an artery to you guys? Does it seem like an artery to you guys? Because artery is this one, eh? Artery is this one, and you can see it. That's the artery, guys. Okay. Flexor digitorum, yeah, deep branch of an nerve tendon of flexor digitorum. No, 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 no. Guys. Hapa nimewakamata tena. Hapa, guys, what is happening, guys? I thought we agreed you should read the anatomy. Very good. Very good. Whoever those full stops are, that is very good. That's there. No, 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 no. In fact, no. Yes, I think Daniela is correct. That is the common digital branch of ulnar nerve. It's the common digital branch of ulnar nerve. Okay, you can common digital nerve. No, it's more of a branch. So that's the common digital branch of ulnar nerve. And now F becomes the proper. No, no, no. It's not ulnar nerve actually. It's median nerve. Yeah, it's median. That's more median. Sorry. That's median nerve. Yeah, I've seen it's median. Yeah, it's that one. So it's the common digital branch of median nerve. And then from the common digital, if you can follow E, this one, you can see that it now branches. It now branches to give you now the proper digital uh, uh, branches or the nerves. Okay, nerve branch. Okay, so please, this has shown you that you have, guys, please go read on the anatomy of the hand. Go read on those anatomical spaces of the hand. Yes, the mid-palmar space, the palp spaces. Please, guys, for the hand, you need to know the anatomy of the hand because you use your hands each and every day. So please know everything regarding your hands. And that information should be at your fingertips. All right, identify the couple bones. Yes, this is another question that you shall be tested again and again and again. You need to know identification of couple bones. One, scaphoid, very good. So scaphoid done. Two, what's two? Lunate. We are done with scaphoid. Now go to two, lunate. We are done with that. Go to three. What is three? Triquetrium. So I think we can, so triquetrium, Triquetrium. Okay, someone has said pisiform. Okay, pisiform, maybe that one, the smaller one on top. But for this one, I wanted you to get that it is a triquetrium. Okay. Four, what is four? Hey, Mushaenda six. So four, trapezius. Guys, trapezius, is it a muscle? So please use the correct names because if you say trapezius, I know trapezius is a muscle. That will be wrong. So 4 is it trapezoid? I can see people saying trapezoid, others trapezium. Which is which? Which is which? No, no, no. We are at 4. Some are saying trapezius. Eh, Okay, trapezius was said, others trapezium, others trapezoid. Which is which? 4, trapezium. 5, trapezoid. I think we can all agree with that, eh? So trapezium 4, then 5 is trapezoid, eh? 6, what is 6? Capitate. 7, 7, hamate. Sawa. Aya. Please know those couple bones. I will ask you again and again. Please know the couple bones. You will be tested. What is the pattern of blood supply to the scaphoid? Retrograde. Mpaka wameweka avascular necrosis. Daniel huyo ako mbele already. Okay. Let me ask you another question. Which bone of the lower limb has a retrograde supply also? Talus. Okay. Talus. Those patterns of blood supply, retrograde, watershed, and the others, they might make an appearance in your exam. I'm just saying they might make an appearance, okay? So, yep. So, retrograde pattern, fractures to the neck of scaphoid. Uh, um, Kindly highlight possible blood patterns. Allow me to skip that question at 100 miles per hour. Okay? Because the lecture on patterns of blood supply, there are so many. Okay? So what should you do? Just go to your internet. Just go type patterns of blood supply, anatomy, and then you go to the images. You'll find some guy has made a table of the patterns of blood supply, and that table can actually help you. Yeah, you have to specify which part undergoes a vascular necrosis. Yes, also for talus, like for 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 scaphoid here. It's if you have a fracture of the neck of the scaphoid, that's when you have a vascular necrosis because that is where the vessels are as they go to the body. Also for talus, it's more or less the same, but I'd be more keen to know, do you know the pattern of blood supply? Okay. Kindly identify these vertebra with the reasons. So what vertebra is this? Thoracic. So we can agree this is thoracic. That is wonderful. So what are the reasons? I want reasons. What are the reasons? You might not find this question in your short answer question, your SAQs or your, but these are the kind of questions which you are asked in your vivas. Heart-shaped body. Daniela, if you tell me that, tunakosana. Tunakosana. My heart is not shaped like that. I can tell you that for a fact. 1, presence of costal facets. Yes, you can see a costal facet here on the transverse process. That is wonderful. You can also see demifacets on the body. So those are 2. So demifacets on the vertebral body and a costal facet on the transverse process. That is a reason. Those are 2 reasons. Spinous process facing inferiorly. Wonderful. You can see this is a spinous process. It is directed downwards or inferiorly. Coronary oriented articular facets. Wonderful. Wonderful. That is very good. So coronary oriented. So these here are the articular facets. Those are the superior articular facets. This one's here, that one, that's the inferior articular facet. They are coronary oriented. Those of the lumbar region are sagittary oriented. Right. Those are very, very good reasons. Long spinous process, apana. Apana. Narrow spinal canal, apana. Narrow triangular spine, apana. Is it, it is, they are coronary oriented. They are coronary oriented. These, you are looking at these articular facets. So if you look at them from behind, that articular surface is coronary oriented. Remember the three anatomical planes, sagittal, coronal, axial, transverse. This one is coronal. Those are the reasons. Kindly, when giving reasons, use anatomical features. Avoid using adjectives as much as you can. Adjectives are describing words. Avoid using those. If you start saying heart-shaped, no, you are going the wrong way. Use anatomical features. You can see what I've used anatomical features. The spinous process is directed downwards. That's an anatomical feature. It has a costal facet on the transverse process. That is an anatomical feature. It has demifacets on the body. That's an anatomical feature. The articular facets, what are referred to as the zygapophyses, those ones are coronary oriented. Those are anatomical features. Okay. I won't say much of this. I will just point one or two. I just point one or two, and then the others you go read, because I can tell you for a fact. Foramina, these ones will be tested. I was tested as a first year, and I was a first year around 4 years ago, and all the other cohorts have been tested. Okay, so the three cohorts that have joined after I finished first year have been tested. You as the fourth cohort joined first year. Why do you think you won't be tested? So what is that? Name A. What is A? What is A? Magnum. Where? Guys, kindly write the full names. Foramen magnum. It's foramen magnum. Now, can you tell me ligamentous structures? Ligamentous structures that pass through A. What ligamentous structures pass through A? One, apical ligament of Denso. Very good, very good. Two, tectorial membrane. Very good, very good. Another one I've seen, the cruciform ligament. Okay, very good. That is the superior longitudinal band of, is it cruciate? No, not cruciate. Well, bacteria, not cruciate. It's cruciform, not cruciate. Cruciate iko kwa magoti bwana. It's cruciform, Cruciform, okay? And also the ala ligament. Naona mko sawa. Very good, very good. Those are the ligamentous structures. So apart from knowing, most of you, when asked, name the structures that pass through foramen magnum, spinal cord, vertebral artery, spinal accessory nerve, and then you are done. There are so many, yeah? Let me just point another one. Yep, let me just point this one as the last one, B. What is B? What's B? Optic canal. So apart from, these are the types of questions which will be brought. Apart from optic nerve, and ophthalmic artery. No, guys, apart from optic nerve and ophthalmic artery, name two other structures that pass through the structure report B. Yeah, now I can see people have a type 10. Meninges, very good. The central artery of the retina, very good. The central vein of the retina, very good. Ah, mko sawa, mko sawa. Does CSF also pass through there? Does CSF pass through there? Yes. So if you like CSF, mko sawa. Sympathetic nerve from carotid, hapana. Hapana, hiyo tumekataa. Sympathetic hapana. Hiyo hapana. Hiyo tutakataa. So guys, um, for each of those foramina, kindly have an idea. Kindly have an idea of, don't just cram one structure which passes through there. That one structure which you have crammed, in the exam you'll find apart from that one structure you have crammed. Now you'll have a bad day. Kindly know the various structures that pass through the various foramina. I will leave it at there. Now, I am into histology, and as you can see down here, Haron Sami, because he is the man who pioneered in the uh, in making of these slides. So, if the histology bit is so good and you find it very helpful, you might want to ask Haron for his M-Pesa number and send him some few hundreds or thousands of shillings. Okay, so okay, huh. Okay, this is weird because I don't know when the answers will now come. Okay, huh. So identify the type of epithelium shown. Simple cuboidal. Simple cuboidal. Remember what I said. These slides were obtained from the department. So this is what will be seen in those microscopes, okay? Simple squamous. Wonderful. This is simple squamous. Why? Why simple squamous? Yeah, we are using this, it is this image we are looking at. Okay, even if it is this one there, it's like the arrow moved. Yeah, one layer of flattened. Yes, flattened is the key, yeah? Flattened. Okay. Okay. So they have that fried egg appearance, Very good. Now on to the second question. Name three areas where you would expect to find this type of epithelium. Very good. Alveoli. Very good. Endothelium. Very good. Where else? Apart from alveoli and endothelium. Rhinocorpuscles. Okay. Cornea. Cornea. Okay. Mesothelium. Very good. Very good. What about peritoneum? Okay. Mesothelium is also peritoneum and the others. Okay. Bowman's capsule. Very good. Endocardium. Kindly highlight possible. Hey, here possible. Hii possible blood patterns simuli hiyo tulisema mwende msome. I don't know why I keep on seeing it coming. Bowman's capsule, corneal, endothelium. Someone is actually, that is very good, brotato. That's wonderful. Instead of just saying cornea, because cornea has 5 layers, you can go and tell us which specific layer is simple squamous. It's the corneal endothelium. That's wonderful. Mesothelium, wonderful. Yep, I think I am good with those answers. Okay. Yeah, you can see the various. I think you've mentioned. You did not mention by the descending loop of Henry. Yeah? That one also has. Yep. What is the function? What is the function of this endothelium? Sorry, this simple squamous. What is the function? Okay, diffusion, filtration, ultrafiltration, faster diffusion. Okay. Yep. Also, gaseous exchange, guys. You just look where is it? It's in the alveoli. So gaseous exchange, uh, um, um, in the blood vessels, maybe filtration and so on. Okay. Um, yep, and that is the slide number H1. No, it's H15. You can go and check it out in your when you go to histology. Yes, identify the type of epithelium. Yes, what type of epithelium is this one? This one here, this one. This one, yes, that one. What type of epithelium is that one? It was this, it was obtained from this area. We have just magnified. Simple columnar. Very good, very good, very good. So what organ is this one, by the way? The one you are seeing down here. B. Which tissue? Where do you think these are come from? Jejunum, uterus, uterine tube. I think whoever has said uterine tube or fallopian tube, that's correct. This is the fallopian tube or the uterine tube or the oviduct. That's how they look like. No, that's not jejunum. It's not jejunum. You'll see how jejunum looks like. It has those plica circularis or those valves of I have forgotten the valves of that guy, but the plica circularis, it does not have such a morphology. So this is the uterine tube, and there we have simple columnar. Okay, where name other areas where you expect to find simple columnar. Where else do you expect to find simple columnar? Jejunum, okay. Renal tubules. Where? Where specifically in the renal tubule? You have to be specific. You know, renal tubule is it's a vague term because the renal tubules extends from your proximal convoluted tubule to your distal convoluted. No. In fact, to your collecting duct. That's a vague term. Alimentary canal. No. Alimentary canal is from your mouth to your anus, and we can all agree that not all that part has simple cuboidal. So small bronchioles, okay. GIT. No. Don't say GIT. Be specific. Yes, say stomach, duodenum, gallbladder, female tract. That is also a vague term. Be specific. Where in the female tract, the ovaries, because no. Okay, the vagina is part of the female tract, and we cannot agree it does not have simple columnar. So my female tract, guys, be specific. Don't just say GIT. Where? Where in the GIT? In fact, a good question has been asked. Is this simple columnar just, or is it simple columnar ciliated? Because actually, I think you should add ciliated because also in the fallopian tubes, it's ciliated. Okay. So you've seen the areas. You can see what is happening here. You see stomach, small intestine, large intestine, colon is large intestine, gallbladder, bronchioles, central canal of the spinal cord, uterine tube. And also, I disagree with the renal tubules. Be specific. Where in the renal tubules? Is it, yeah, the proximal convoluted tubule? Now that's right. So that's HJ13, and it's simple columnar ciliated. Okay. I don't know why they appear in that sequence. Yeah. Okay. This one, very fast. This one. Where are you gonna share the video? The video, the recording will be shared exclusively in my YouTube channel so that you can subscribe. Okay. So worry not, I will send the link to the various platforms. Yes, this is transitional epithelium. Very good. Or the urothelium. Very good. Very good. Very good, eh? Very good. So that's the transitional epithelium. Sorry, yeah, transitional epithelium. Where do you expect to find it? Ureter. Urinary tube. What is urinary tube? Okay, ureter. Proximal urethra. Okay, that's wonderful because someone here knows that not the urethra, not the entire length of the urethra is covered by the urothelium, just the proximal parts. Ureter, very good. Urinary bladder, very good. Renal calyces, very good. Distal male urethra. Distal male urethra. Daniela, distal male. Okay, she has edited. Proximal, that is wonderful. Okay. Um, what are the functions? What are the functions of this type of epithelium? What is the function of the urothelium? So one, distension, very good. Another function. Yeah, apart from distension, what else? What is the other function? Yes, impervious. Okay. Storage, alert the body. Whoever alerts the body is the nervous system. The epithelium has no business with alerting the body. Prevents leakage. Is it protective, guys? Yes, it's protective because if you have bacteria within your urinary bladder, they can't have access to your body because of that epithelium. Okay. Yep. So, yep, this one, what type of epithelium is this one? What type of epithelium is this one? Guys. Fanyani mbio. Time. Glandular. Uh, os trigonum. Simple columnar. Whoever those dots are, that is very good. That is complex stratified epithelium. Very good. That is complex stratified. If you look at it, you cannot even tell what is the shape of the cells at the top. It's complex stratified. And where do you find it? Very good. The seminiferous tubules. So you can see first years. If you ask first years where complex stratified epithelium is, they will tell you seminiferous tubules, testis. But now the issue is, can you identify it? Now that is where the issue is usually. All right. Yeah. Um, yeah, that's HJ15 testis. Um, yeah, and remember what I said, all these slides here, they are from the Department of Human Anatomy and Medical Physiology, University of Nairobi. Identify the type of connective tissue. Which connective tissue is this one? Which connective tissue is this one? Mucus. Yeah. I think we can all agree this is mucus connective tissue. It's a form of embryonal tissue. Remember, embryonal tissue, it's either mucus or mesenchyme. Eh? So this is mucus connective tissue. Why do you say mucus? Why do you say mucus? Why? Why do you say mucus? Yeah, one, these cells, I don't think at this resolution you can make them out, but they are usually spindle shaped, okay? And it has abundant ground substance. That is very good. Eh? Very good. So where do you find this? Where do you find this connective tissue? One, tooth pulp, the Wharton's jelly. Okay, Wharton's jelly is simply that mucus connective tissue of the umbilical cord. The nucleus pulposus, very good. Nucleus pulposus. The nucleus pulposus, it's a remnant of what? Nucleus pulposus is a remnant of which structure? The notochord, eh? The notochord. What about, where is the annulus fibrosus derived from? Where is it derived from? The sclerotum, eh? The sclerotum. Wonderful. Okay. It's HB. Okay, let me go back. Sorry. The slide number is HB8, the tooth of a kitten. Okay. This one, yeah, yeah. Which one is this one? Identify the connective tissue zone and give reasons. Which connective tissue is this? This is adipose. Okay, this is which adipose? Very good. White adipose tissue. Very good. White adipose tissue. Why? Why is it? Why do you say it's white adipose? What is the one? Very good. Unilocular appearance. So unilocular appearance, honeycomb appearance, nuclear pushed to the periphery. Okay, okay. I think we can also take that. Okay, so it's the white or the unilocular adipose tissue. Please go read on the brown adipose tissue. Please go read on the brown adipose tissue and how it would differ from the white. Yep, I think you've stated the reasons, eh? But the brown one, the cells are usually smaller and it has what is known as multilocular appearance, okay? Unilocular means, can see it's just the fat within that cell, it's just within one locule, one big, it's like a one big vesicle, if you can put it that way. But for brown, you'll find instead of it being in one big storage compartment, it has various compartments, what is known as multilocular appearance. What is the function? What is the function of adipose? One, shock absorber, insulation. Very good, very good, very good. So energy reservoir, also in insulation, shape maintenance. Very, yes, it also maintains your shape. Endocrine functions. Can you tell me what endocrine? Can you name me three endocrine hormones or three hormones produced by one leptin? That is very good. Another one apart from leptin, adiponectin. Very good. Adiponectin. What else? Very good. Resistin. Very good. Resistin. Yep. Very good. That's wonderful. I had seen, how do you differentiate non-lactating mammary gland adipose? Okay. Now, non-lactating, you will see the ductal components. You do not expect to see any ducts or any ductal component within adipose tissue. So if you see a ductal component, any ductal components, think about mammary. Alveoli. Huh. Alveoli, the way I usually identify alveoli is they have very many capillaries. It's highly vascularized. Remember, adipose, you don't have very many vessels in the adipose tissue. It's poorly vascularized, but in the alveoli, you expect a lot. In the lung tissue, you expect high levels of vascularization. That's the way I would put, that's the easiest way to differentiate, but you have very many other ways to differentiate it. As you move on, you'll be told, you will see alveoli tissue, you'll see mammary gland tissue, and you yourselves will find other ways to differentiate it. That's HA8. Yep, this one. Which fibers are shown? Which fibers are these? What fibers? What fibers are these? Okay, can see people are saying reticular fibers. No, 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 no. I asked the fibers, not the tissue. Yeah, the tissue here, this is the liver, okay? Under silver stains, this is a silver staining. So this is the liver. So what is the fibers? The fibers here are the reticular fibers. Remember, reticular fibers is collagen type what? Reticular fibers is collagen type what? Type 3, yeah? Type 3, so where do you find, um, do they ask about staining? No. No, 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 they do not, eh? They do not ask you about staining. But if you are a BSc anatomy student, they will ask you 101 questions on stains. So, yep, where do you find it? One, very good, the spleen, the liver, the lungs, okay. Bone marrow, very good. Dummies, no, 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 dummies, hapana. Okay, is it lymphatics or the lymph nodes? Yeah, I think it's the lymph nodes, eh? Lymph nodes. So any reticuloendothelial organs, so spleen, liver, bone marrow, and the lymph nodes. So spleen, liver, bone marrow, lymph nodes. That's where you find thyroid, apana. Thyroid, apana. So go read on the reticuloendothelial system. Find out which organs form the reticuloendothelial system, because that is where you find the reticular fibers. Okay, those are reticular fibers because they have they are highly branching, and they form a network. They form a network. So where do you find collagen type 1? I'll ask type 1, type 2, and type 4. Where do you find collagen type 1? Where do you find collagen type 1? Guys, which connective tissue? Just can't say connective tissue. Where? Yes, dense regular connective tissue. Now that is an answer. Skin. Where in the skin? Skin is vague. Skin is a vague term. Tell me where. Because if I go to the epidermis, which is part of the skin, I don't expect to find collagen. So bone, that is wonderful. Tendon, wonderful. Aponeurosis, good. Perichondrium, wonderful. Fascia, very good, yes. Okay. What about type 2? Where do you find sclera? Wonderful, wonderful. Where do you find type 2? Where do you find collagen type 2? Cartilage, eh? Notochord. Okay, notochord is a form of cartilage, embryonal cartilage. So just there. So hyaline cartilage, elastic cartilage. Okay. What about type 4? Where do you find collagen type 4? Basement membrane, eh? The basement membrane. So you can say basolamina, which is basement membrane. Okay. Can they ask about collagenopathies? Why not? Yeah, you should know those collagenopathies associated with the various types of collagen. So type 1, osteogenesis imperfecta. Type 4, Alport syndrome. Yep, a question or two. May, okay? So I know collagenopathy, that is under pathology. So you might be asking yourself, what the hell is pathology doing in anatomy? But yeah, they are all connected, okay? Okay, so type 1, bone, skin, tendons. Okay, I'll also ask skin where, because I tend to think it's the dermis, eh? Better write dermis. Organ capsules, sclera, dentin, very good. Yeah, type 2, there. Also the intervertebral disc. Type 4, basal lamina of epithelium, the kidney glomeruli, the lens capsule. Yep. Um, Alport. It's Alport syndrome. Alport. Associated, it's a collagenopathy affecting type 4. So you ask yourself, if my type 4 cartilage is affected, this is the way you think about pathology. The good thing about pathology is, if you know the anatomy, pathology, once you come to that, yeah, pathology would be very easy. It would be making sense, because you'll know that type 4 cartilage is in my glomerulus. If I don't have that collagen type 4, if I don't have a basement membrane, how will I present? Blood will leak into the urine. So I'll present with blood in urine. Also, you find a basement membrane in your alveoli. So I'll present with blood in sputum. Okay, so that's how they present. You just ask yourself, where is it? And if it's not there, how will I present? It becomes very easy. If you don't know that now, no, pathology will never make sense. That's H9, and that's the function of the reticular fibers. They are supportive and they form the scaffolding, the supportive scaffold of various reticuloendothelial organs. Yeah, it's a supportive meshwork. Very good. Okay, I think we go faster kidogo hapa. Identify the structure. I know it's nine. It's nine, but you will give me just 30 minutes and I will be done. Remember, you still have embryo. I think we are coming to the end of histology. Guys, what structure is this? Yeah, I'm talking about this one here. That one. Yeah. Yes, that is the epiphyseal growth plate. Very good. Epiphyseal growth plate. Can you name the layers? Can you just name two layers of that growth plate? Name two layers or two zones. The resting zone, zone of proliferation, zone of hypertrophy. Yeah, very good. Eh? Which of those zones is the weakest? Which of those zones is the weakest and hence prone to fractures? Which of those zones is the weakest and hence prone to fractures? It's the zone of hypertrophy, okay? Because the cells there contain no calcium, eh? They are not calcified, eh? So uh, there is no calcium, so it's the weakest, eh? Yeah, yeah, yeah. So it lacks collagen and also it does not have, that's HB7. I'm going to check it out. This one, name this one? Which type of bone is that one? What type of bone is that one? Guys, yeah, that's trabecular bone. What's the other name of trabecular bone? Spongy bone. Okay, spongy bone. What is the other name? Cancellous, eh? You can use those interchangeably. So how is bone formed? State two processes in which bone is formed. What are the two processes of bone formation? Intramembranous and endochondral ossification, okay? I won't bother to ask you functions of bone. This is spongy, not sponge, sponge. I won't bother to ask you. Okay. Yeah, this one. What structure is this one? What structure is this one? Hey, hey, tulisema nini? Wait, DRG, who is DRG? Go back to the slide. Okay, okay, okay. Tulieni, guys. Yeah, this bone here. This bone here is the trabecular bone, eh? So who is DRG? Kindly use that dorsal root ganglion. Even in your exams, guys, haraka ni ya kwenda wapi? Where are you running? Just write dorsal root ganglion. Okay. And why is it dorsal root ganglion? Why have you identified as dorsal root ganglion? Presence of satellite cells, that is wonderful. Open face. What is open face? Done. Open face. Face of Uso. It's face. It's a face. The PHASE, not face of the front part of your visceral cranium. So it's face, eh? As virus and bacteria have. So this is an open face nuclei. Okay. Okay, and these are the satellite cells. Those are the satellite cells. Okay. Where does it come from? What's the origin? What's the origin of the dorsal root ganglion? Neurocrest cells, eh? Kindly do not forget that. Okay, name one disease affecting this structure. Okay, this question might be not for your level, but okay, this is more of pathology. HIV, hapana. Herpes zoster. Okay. And anything else? Polio. No, 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 no. Polio, no. Polio has no business with your sensory. Polio has business with your anterior horn cells. That's where polio goes, the polio virus. That's why you have paralysis, Alzheimer's, meningitis. Okay, tuachie hapo guys. Tuachie hapo. No, no, no. Rabies hapana. Rabies mainly affects the brainstem nuclei. Okay, it mainly affects the brainstem. Okay, this one. Name this one. What structure is this one? Kwani umeacha kutype? Guys, peripheral nerve. Atiai, peripheral nerve. Peripheral nerve. Whoever 4D is, you need to find out who that guy is. That one is not a first year. Huyo si first year. I think we can all agree that whoever 4DR is, that is not a first year. I think it's one of the BScs who has joined. Yeah, this is the thyroid. Kindly be able to differentiate the thyroid and the dorsal root ganglion. Let me go back because kindly note how a dorsal root ganglion looks like, eh? And then kindly note this is thyroid. I know they seem the same, but trust me, be able to differentiate it because most students have difficulties. Now that I have said it is thyroid, I will find you in your exams saying the dorsal root ganglion is thyroid. Huh. I wish I had not said that. Okay. Okay. What is A and what is B? What is A? What is A? Pakinje. Pakinje. B. Stellate. What is A, guys? Okay, apicodendrites. But what is the cell? Apicodendrite is not a cell, bwana. Hey, dendrite is a cell. I asked what is the cell named labeled A. It's a pyramidal cell. That's the name, or a pyramidal neuron. That's the name, eh? What is B? What is B? What is B? Stellate. Stellate. I think it's okay. An astrocyte. Is it stellate? Hii mambo imefunzwa. I thought you guys did a histology of the cortex. Ama have you been taught histology of the cortex? Maybe I am bado. Oh, you guys have not been taught histology of the simple squamous. You guys have not been taught the histology of the cortex. We've been taught. And why? Ati TV kufanya kazi? No, no, no. TV kutofanya kazi does not mean you should not know. I thought I saw. Yes, it has been taught. You have not done. Yeah. By the way, note anything in your timetable, whether it was taught or not, it is likely to make an appearance in your exam. Okay? You guys, you mean histology, you've not been taught histology of the cerebral cortex recently? Not the one you are taught. Okay, okay. Sawa, hii hata ninaruka ati lateral inhibition. Okay, no, 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 no. Acha hata niruke tu. Chop, chop, chop. Nimeruka. Sawa. Nimeruka hiyo. Kama haijafunzwa, kama histology of the cerebral cortex was not taught, I don't think I will bother you with that. Okay, so identify, identify. Ati usiruke. So you guys have told me you are not taught cerebral cortex, histology of the cerebral. Sasa mumeniambia kwa hivyo mlifunzwa. Ati wacha tuone tu. Ana anasema tulia Onyi. Eh, 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 eh. Eh, 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 eh. Oh, you guys want to see the answers. Aye. Aye. Kwani okay. They just want to see the answers. Okay, A is the pyramidal neuron, B is a protoplasmic astrocyte. We have two types of astrocytes, one in your green, another one in your white. This one in the gray matter is the protoplasmic, the one in the white is the fibrous. And then cortical module refers to the basic functional unit of the cerebral neocortex. So the neocortex, the basic functional unit of that neocortex is what is known as a cortical module. And it has those eight characteristic features of cortical module. You will be taught this. If it has not been taught, to the end, relax. Okay, hii bado. Okay, okay, sawa, sawa. Okay, now simu name hizi. Hii mkiniambia mjafunzo si tunakosana. What is one? What is one? Eh? Roof plate, very good. That's the roof plate, very good. What is two? What is two? Ati hiyo ni nini? Admin. Hey. What is two? Central canal. Central canal. You dare name it central canal. You name it central canal. Hey. No, no, no. We are at two. We are at two, bwana. Okay. Two is the neurocanal. Primitive streak. Primitive streak. That's the neurocanal. Please note this is the neurocanal. Ati hii ni part gani ya mwili? Tushaenda embryo. We are already in embryology. You think this is histology? We are no longer in histology. We are now in embryo, bwana. We are in embryo. And nobody in your exam will be telling you now we are in embryo. No, nobody will be telling you that. It is upon you to see histology. They are even screaming. Ooh, we. I hope you do not scream in your exams. So, what is two? Neurocanal. Okay. Ventricular. Hey, apana. Okay, three. Three is the ventricular zone or the ependymal zone. That is very good. So three is the ventricular zone. What about four? Which zone is four? Which zone is four? Number four. The mantle zone. Very good. The mantle zone. The mantle zone. Okay, it's a zone. Okay, you can also call it a plate. Okay, okay. So just say it's the mantle zone, eh? Um, what is five? What is five? What is five? Floor plate. Very good. Floor plate. Very good. What is six? What is six? What is six? What is six? Hii hapa. This one. Um, we can just name it spinal ganglion. Let us call it spinal ganglion because we do not know is it the dorsal one or is it maybe the sympathetic one? Let us just call it spinal ganglion. Eh? What is a what is seven? What is seven? Very good. Now this is the basal plate, and now this is the, what is 7 is the basal plate, and 8 alarm. Alarm tena. The ala plate, eh? The ala plate. Okay. Okay, yeah. We can see we have Manchester United fans, which is wonderful. Eh? Yeah, they are doing the Lord's work. Now, um, identify where does it originate from? Okay, guys. Hey, 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 hey. Football will still be there even next year. I hope you are not here next year. Yeah, football will there be even next year. But you guys, for you, I don't want to see you here next year. Okay? And hey, no, 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 guys, you cannot use my username as your profile name, bwana. Mbona ujiandike Wallace tena? No, 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 no. Guys, no, 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 no. There is only one Wallace in this school, and that is me. There is no one else, one. Kindly don't, don't, you can call yourself Wallace's son or daughter, but not don't use no, 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 hapana. That is only me. Utachoma wewe. What is okay? What are the derivatives of 7? What are the derivatives of 7? By the way, guys, I do not have answers here. I hope you are following because I don't have answers. You think that as I go forward, you'll see the answers. No, hapa hakuna. Very good. The ventral horn, very good. The lateral horn, very good. Also the motor neurons. Wonderful. Wonderful. So we said 4. We named 4 as the mantle zone. Eh? We call it the mantle zone. We said 7 is the basal plate. I know you might not, you might ask why 4 is the mantle zone and not the basal plate. I also don't have an answer. And we said 8. My pen has ati hii mlisoma wapi? Guys, kwani you guys did not go through embryology, parts of the neurotube? Hey, ati you guys have also not been taught development of the spinal cord. I saw it in your objectives. It was in your objectives. Okay. Okay. Oh, so you think simply because Dr. Han did not teach, um, Ali postponed. Ha. Okay. But parts of the neurotube you should have. See, you guys were taught neurulation. Eh? See, you guys were taught neurulation. Okay, maybe you might not know the derivatives of the various parts of the neurotube. Okay. Na venye nilikuwa okay, this one must have been taught. What is the name of this one? Name this. What is that? What is that? Kindly name that. Eh, yes, thank you, Kuria Juliet. Very good. Apical ectodermal ridge. And also thank good work myself. Apical ectodermal ridge. Okay. Kindly, whoever is using the username Wallace PSC, kindly, if you answer any question wrong, I will ask you to kindly change it back to your own name. So that is the apical ectodermal ridge. What is the function of the apical ectodermal ridge? Proximal distal growth. Very good. So it establishes establishment of the proximal distal axis. Okay, very good. Very good. Which signaling center is responsible for the establishment of the anteroposterior axis? Which signaling center is responsible for establishment of the anteroposterior axis? Very good. The zone of polarizing activity, ZPA, the zone of polarizing activity. It's the one which establishes the anteroposterior axis. So the anomaly would be now any anomaly associated with the proximal-distal axis if you have damage. So lengthening, you'll have a defect in the lengthening. So a media, polarizing or polarizing. Brotato does not matter. So micromedia, a media, and such. All right. So I want you guys to name what A is, what B is, what C and D is. What is A? What is A? Very good. Paraxio mesoderm. Very good. Paraxio mesoderm. I hope you guys know derivatives of paraxio mesoderm. Can you name the derivative of the paraxio mesoderm? Uh, uh, okay, guys. Allow me to take a call for my mother. Just give me a minute. I'll be back. Okay, more of 5 minutes. Okay, sorry for that. So let us continue. I was saying you must know the derivatives of um the the various parts of the mesoderm. So you said what's A? A, you named it as the paraxia mesoderm. I hope you know the derivatives. Um and no. Sikuwa nasherehekea. Um I was literally calling my mother, guys. No. I received a call from my mother. I had to take it. Um, B is the intermediate mesoderm. What is C? Guys, what is C? Guys, what is C? The somatic plate. The somatic plate, that's the somatic plate of the lateral plate mesoderm. Sorry, it's the somatic layer. The somatic layer of the lateral plate mesoderm. And D is the splanchnic layer. Okay, the splanchnic layer. For now, just guys, allow me to just name them. Please go find out the derivatives for the sake of time. What is A here? B and C. What's A? Guys, what is A? Very good. That's the notochord. That's the notochord. What is B? What's B? What is B? What is B, guys? Paraxio. No. Guys, what is B? Guys, B is not paraxio. Crest, no. Yeah, very good. That's the sclerotome, eh? That's the sclerotome. B is sclerotome. What is C? What is C? What is C? If B is sclerotome, C becomes your dermamyotome. Very good. Dermamyotome. So please know the various components of the somites or parts of the paraxial mesoderm. Eh? Please go find out the derivatives of each. Eh? Yep. Then, yep. What is this structure? I'll name it as A. What is that? What's A? What is A? What is A, guys? Yeah, those are the neurocrest cells. Eh? You can see those are the neurocrest cells. You can see they are migrating. Eh? Those are the neurocrest cells. Eh? Please go know the derivatives of the neurocrest cells. I'm sure that one, I'm sure that one you guys know. Okay. Yeah. What's A? Name the now. I think we are coming to the end. A, B, C, D, E, F, G, H. Just say the alphabet and write the one which you know. A for comedia. No, A is not for comedia. C for comedia. Wonderful. B for comedia. Pana. F, syndacty. Wonderful. A, meromedia. Very good. A is meromedia. B, amedia. Very good. C for comedia. Okay. C is your for comedia. Okay. C for comedia. D, what is D? What is D? What is D, bwana, guys? E, brachydactyly. Very good. Eh? Fetus, papi, no. In regards to no. This is not the harlequin fetus, bwana. In regards to the upper limb, what is D? Ati paprahu. Aye. H. Et, eh? H. Ectrodactyly. Very good. That's the ectrodactyly. Ati, hey, arthropogos. Hey, guys, what are those? G. Postaxial polydactyly. Okay. G is postaxial polydactyly. D, meromeria. Is it meromeria? Guys, please let us know the differences between meromeria because D is micro. D is micromedia, okay? Please go find the difference between meromeria, focomedia, aneria, and micromedia. I think, yep, that one is done. Meromedia, aneria, focomedia, micromedia, brachydactyly, syndactyly, postaxial polydactyly, and ectrodactyly. ducting. Go know the difference between micromedia, pocomedia, meromedia, media. Hiyo ndo kazi sasa. And the anatomical basis. Have you guys been taught development? Must you say postaxial? Okay, make it a habit to say if it is postaxial. Remember, postaxial is to the side of your small finger. Preaxial is to the side of your thumb. Have you been taught development of the mammary glands? Has that been taught? Has the development of the mammary glands been taught? Aha, very good. So these are the answers are already here. So this is polyphilia, access nipples. You can see here we have mammary gland within the axilla, so that's axillary polymastia. This individual has the mammary glands, but the nipples are absent. Athelia. This individual has um, um, uh, um, one absence of breast on one side, what is known as unilateral amastia. Okay, it can be bilateral or unilateral. Okay, amastia and amasia. What is amasia? Why is D not Poland syndrome? For you to know it's Poland, you'll have to now is the muscle here, which I would say the muscle is because I can see this is part of the clavicular part, the clavicular head of sternocleidomastoid. Sorry, the clavicular head of pectoralis major. So Poland syndrome, it's pectoralis major absence. Okay. Okay, name these ones. A, B, oh, shoot. B, C, D, E, and F. What's A? A is vitiligo. Please know the anatomical basis. What is the embryological basis? What is the embryological basis of vitiligo? What is the embryological basis of vitiligo? Guys, what is the embryological basis of A? Autoimmune. Autoimmune is that, guys? Aye. Autoimmune embryo. Full autoimmune. Autoimmune embryo. No, 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 no. I disagree with that. What is the anatomical, what is the embryological basis of vitiligo? You know, vitiligo can be congenital or acquired. The one which I'm displaying here in embryology, this is congenital. What is the embryological basis of congenital vitiligo? Acquired vitiligo, yes, autoimmune. But why would I give an image of acquired vitiligo and we are in an embryology class, in a developmental anatomy class? Absence of melanocyte. Yes, why? Why is it absent? Why? What happened to them? Ability to synthesize enzyme, tyrosinase. Hey, that is for albinism, bwana, not vitiligo. Autorecessive. Guys. Localized melanocyte defect. No, no. Why? What is this defect? You guys don't know the basis of congenital vitiligo. Thank you, Hassan. Thank you, Hassan. Yes, it's failure of migration of neurocrest cell to that site. So if neurocrest cells do not migrate to that site, melanocytes won't develop at that site. So you'll have vitiligo at that site. So it's a migration. It's a neurocrest cell migration issue. Okay. B is hypertrichosis. C, I saw you said ichthyosis. D, you said the port wine saying. What is the other name of D? What is the other name? What is the other name of D? The other name, apart from Portweinstein? Hemangioma. Um, Cavernous hemangioma. Okay. Yeah, yeah, I think, yeah, B. Okay, B is hypertrichosis or the werewolf syndrome. Okay, it can be part of that syndrome, the werewolf syndrome, but itself is hypertrichosis. Okay, then E is now whatever they are saying here, Harlequin. Harlequin ichthyosis is just a form of ichthyosis, which is severe. What is F? What is F? Hey, guys, kuweni serious bwana. What is F? Albinism, eh? F is albinism. Okay, I think I am done. Yeah. If you have any questions, the recording will be uploaded in my YouTube channel on Med Content, so you can follow so that you can see it once it has been uploaded. For those who we haven't met, I think that was me back in 2024. Maybe I should change that photo. I've become old. Back then I was youthful. Now I think I am very old. Yeah, kindly follow my LinkedIn channel. Okay, let me tell you things which maybe you won't be told by lecturers. Kindly, as a medical student, have a LinkedIn channel. In LinkedIn, you'll get very many opportunities. In LinkedIn, that's where people post opportunities for medical students which you can participate in research. Most of them are usually free. Yeah. Um, I remember it's on LinkedIn that I got an opportunity to 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 get a grant to travel to Zambia to present my research work. So LinkedIn is it's a good place. Okay, I also have Instagram for those maybe who want to see my non-academic side. Yeah, that is what I consider fun. Also have Facebook so that I can keep track of my father's post. That is the only place where we can interact with my dad. Yeah, so that's why I have a Facebook channel. Yeah, ujana ni moshi. I can tell you that. Yep, ujana ni moshi. Once you start hitting the age of 20, 24, 25, your back even starts to ache and you tend to sleep early. In fact, this is past my sleeping hours. Eh? I am not on TikTok. I am not on TikTok. I also am not on Snapchat and those others. I am not there. Okay, asanteni sana and success in your exam. Mko na maswali. How do you read behavioral science without reading? Ai, wewe wacha mambo wewe. Hey, how do you read? Kuna kitu kama hiyo. Soma hizo models. Soma hizo model 1 hadi model 10. Soma hizo units bwana. You have to study bwana. Si ni wewe ulijichagulia course? Hmm? Si ni wewe ulijichagulia course. So how else had you why had you? Yeah, you can also decide to cram it. So any other questions bwana? By the way, is it postponed or was it? No, no. Mimi sasa hizo ni maswali gani mnaniuliza mimi? Guys, real men should not have TikTok. I did not say that. Slides. Hizi slides hizi mtaonea kwingine bwana. Just slides. Okay. I think I can convert them and send them by tomorrow. Any other questions? Any other questions? Kindly don't ask anything about my personal life. Kindly let the questions be in regards to this session. Msianze kuniuliza maswali zingine. I am saying that for those who are sending private questions. Wacha wewe. If your question you cannot send to everyone, kindly don't send it. When are you uploading to YouTube? Soon. Soon, soon, soon. Si chakula bwana. Let me hata go and eat. Any other question, guys? You know, it is past my sleeping hours and my back is already aching. How is Fordia taking you? Fordia is just going well. Okay. It's just some few units, just surgery, internal medicine, psychiatry, and community health. Those are just some good units. Just read them and you pass, you pass, you pass. Nowadays, I am not as let me say I'm not as industrious as I was in first year. Yeah, in first year and second year, I remember I would study. Nowadays, think as you grow old, you realize that there is more to study. But studying is also it makes part of the central. It's central, but you realize you have a life to live. How to pass anatomy. Guys, see, I sent you I literally have made a PDF of how to ace anatomy by myself. I wrote that PDF. Melvin, you have not gotten that PDF? Yeah, 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 yeah. Kindly someone, if you are Melvin's friend and you have that PDF, it's just like 6 pages. How to pass anatomy. Weka hiyo. Tumia yeye. Ulipata ngapi cut 1? No, those are personal questions. Those are personal questions which I will not answer. Okay, so I think we are done. You guys don't have any questions. Have a great evening ahead, and once again, Grody, Man United. Thank you very much, Man United, for doing a good job. So I think someone has even sent it in the chat box here, how to use anatomy. Yeah, Melvin, download it, and before I end the meeting, once you download it, let me know in the chat box. Say you have downloaded it so that I can end the meeting. Otherwise, if I end the meeting, you won't be able to download it. Melvin, I'm waiting for you to tell us downloaded. Wonderful. So let me end the meeting. Have a great night, everyone, and success in your exams. Bye-bye.